Hi, I'm Dr. Anita Clayton. I'm the David C. Wilson Professor and Chair of the Department of Psychiatry and Neurobehavioral Sciences at the University of Virginia in Charlottesville, Virginia. I'll be speaking today about the FDA draft guidance on low sexual desire and arousal. And I'll be discussing the new shape of clinical research and the development of clear clinical categories and diagnostic guidelines. These are my faculty disclosures. I'd like to talk a little bit about the background for the draft guidance. There was initially a draft guidance on female sexual dysfunction issued in 2000 and subsequently withdrawn. This new FDA draft guidance is both from the Center for Drug Evaluation and Research, or CDER, and it involves the Division of Bone, Reproductive, and Urologic Products. They have titled this draft guidance, Low Sexual Interest, Desire, and/or Arousal in Women, and Developing Drugs for Treatment. And they offered this for public comment October through December of 2016. The modifications that are most prominent in the new draft guidance are related to changes in the diagnostic criteria from the DSM-4-TR to the DSM-5. And we'll talk about that a little. The diagnosis in DSM-TR were Hypoactive Sexual Desire Disorder and Female Sexual Arousal Disorder, and those were merged in the DSM-5 to Female Sexual Interest and Arousal Disorder. Some of this came about also related to the Patient-Focused Drug Development FDA public meeting and scientific workshop on FSD held October 27th and 28th in 2014, because it became very clear that experts had opinions that maybe differed from the FDA in terms of what should be required in clinical trials for medications to treat FSD. The draft guidance allows for clinical trials to be designed for treatment of conditions of low sexual interest, desire, and/or arousal in women that caused marked distress or interpersonal difficulty. They've actually focused on female sexual interest and arousal disorder, but also hypoactive sexual desire disorder and female sexual arousal disorder are allowed to be continued to be used as primary diagnosis for potential treatments. There's the discussion then about the design of Phase 3 clinical trials, and I'll speak to some of this in the course of this talk. Despite the FDA's focus on FSIAD, it's unlikely that companies will use the FSIAD diagnosis only, as there's no field testing of the diagnosis. There are no instruments validated to measure change using that diagnosis, and therefore there's a higher risk of a failed trial. In addition, this diagnosis is very much controversial within the sexual medicine expert community. Now, in the draft guidance, there are a couple of positive changes. First of all, the FDA has acknowledged FSD as an unmet medical need. And this is critical. They chose 20 unmet medical needs, and FSD is one of those. They also removed the requirement for satisfying sexual events as a primary endpoint. Satisfying sexual events are basically a question asked of women after they've had sexual activity about whether they found it satisfying. And that's in their own determination. It may or may not be related to having an orgasm, or it may or may not be related to feeling emotionally close to their partner, etc. So it's a very individualized discussion and really came from successful sexual events that were used in male erectile dysfunction studies to indicate that an erection was firm enough to penetrate a vagina for intercourse. So that was considered successful. Satisfying is a modification, and is not a very well-defined topic of measurement. Now, they removed the requirement for SSEs to be a primary endpoint in populations with So the FDA has said that satisfying sexual events do not have to be used as a primary endpoint in populations with HSDD. What they said was that it was acceptable to use measures of change in desire and associated distress about level of desire as primary endpoints, and allowed for satisfying sexual events to be a secondary endpoint. However, they still prefer satisfying sexual events be a primary endpoint, as they like to count, and this is an easy thing to count. The problem is that sexual events, much less whether they're satisfying or not, are not a criteria for the diagnosis of HSDD or for FSIAD. And satisfying sexual events have never been validated as a measure for any kind of female sexual dysfunction. Now, there are a couple of unresolved issues that persist in the new draft guidance. And one of those is that the FDA seems to lack understanding of sexual desire in women. The truth really is that desire is a gestalt, although it may be increased related to an event. I think the understanding of sexual desire, and therefore problems with sexual desire, is best addressed using the International Society for the Study of Women's Sexual Health, or ISWISH, nomenclature. What that nomenclature says is that HSDD manifests as any of the following. This is more the gestalt: lack of motivation for sexual activity as manifested by reduced or absent spontaneous desire, that is, sexual thoughts or fantasies. It also may be represented by a lack of motivation for sexual activity manifested by reduced or absent responsive desire to erotic cues or stimulation, which would be somewhat event-related, or an inability to maintain desire or interest through sexual activity, also potentially event-related. So this issue of desire really is this gestalt and potentially increased or increased motivation occurring along with various aspects of cues or stimulation. HSDD also manifests as a loss of desire to initiate or participate in sexual activity, so behavioral changes. And these include behavioral responses like avoidance of situations that could lead to sexual activity that's not secondary to pain disorders. And then the desire really needs to be perceived as a problem to the woman, so she has to have clinically significant personal distress, and that would include things like frustration, grief, incompetence, sadness, loss, sorrow, or worry. In addition, female sexual arousal disorder is defined as an inability to develop or maintain genital arousal, and subcategories. In addition, female sexual arousal disorder is defined as an inability to develop or maintain genital arousal, and subcategorized as related to neurovascular injury or dysfunction or central nervous system activity related to information processing of sexual stimuli. One of the things is that interest as a concept has not really been studied, but if you look at definitions of desire and interest, you find that interest is more an area of attention and concern for something. It's sort of an intellectual curiosity, versus desire, which is something that is wanted or wished for earnestly, resulting in strong attraction or motivation, which is very different than interest, such as is seen in female sexual interest and arousal disorder, which does not address sexual desire or that strong feeling. One of the other unresolved issues is that the FDA is uncomfortable with patient-reported outcome measures, or PROs, especially broad diagnostic tools. They instead prefer single items, such as satisfying sexual events, like counts of events, or single items for the female sexual distress scale. They're even uncomfortable with the 2 items that are part of the Female Sexual Function Index desire subscale. With conditions involving the CNS, such as psychiatric conditions, broad PROs have been developed and based on PRO guidance, and thus are widely accepted as primary endpoints in clinical trials, such as major depression. Clinical trials use the Hamilton Rating Scale for Depression or the MADRS. PROs are definitely an appropriate measure in women with HSDD, which is a CNS active condition. They also did not change the requirement for The FDA also did not change the requirement for separate studies or analyses for pre- and postmenopausal women. Now, that might be appropriate for hormonal products, but it's really not supported by data for CNS active drugs. The treatments that target the sexual dysfunctions involving the CNS should follow the requirements for other CNS conditions, like psychiatric disorders, which do not require separating women into pre- and postmenopausal populations. This is really a hangover in this division from review of sex steroids as interventions for systemic conditions which have been divided by gender, such as use of oral contraceptives or treatment for hypogonadism. It really has no place in sexual disorders, which are physiologically similar between the sexes. A few more unresolved issues. The FDA still requires a minimum 24-week trial of blinded medication. This really is not supported by published data on CNS drugs. The sponsor should determine, and there seems to be a gender difference in the FDA for the duration of trials required for sexual disorders. Clinical trials for sexual dysfunctions or disorders in men do not require 24-week trials. For example, even daily use of PDE5 inhibitors for erectile dysfunction and lower urinary symptoms with BPH trials were 12 weeks. In fact, the recent FDA briefing document of December 6, 2016, from the Center for Drug Evaluation and Research and the Division of Bone, Reproductive, and Urologic Products, the groups involved in the draft guidance we're discussing today, when they talked about treatment of hypogonadism, they cited a 6-week trial for change in levels of testosterone, nowhere close to 24 weeks. What is probably appropriate is that the sponsor should determine the time period a drug exerts its effect in order to inform the duration of the trial. Higher dropout rates with a longer trial duration, for example, 24 weeks, make it, let's go back to the before I started talking about higher. The data actually support 2 12-week trials in HSDD for acute effect, within a subsequent extension study to show maintenance effect would be appropriate for registration for a treatment. One of the problems with the 24-week trial is that we see higher dropout rates the longer the trial duration is. It becomes very difficult to retain non-responders for 24 weeks when they're not being provided symptom relief for their condition. The FDA also mentioned usefulness of a placebo run-in period, which is something that's also been used in psychiatric clinical trials or CNS treatments. It's really, The usefulness of a placebo run-in period has not really been demonstrated if placebo responders are excluded. So that is, if you have placebo as a single-blind treatment occurring in the first 2 or 4 weeks of a study from baseline, if people are placebo responders, they could be eliminated from the study. That is probably not a very effective way to utilize the population and is no longer being used in psychiatric conditions, clinical trials. Let's go back to that. The FDA has suggested a placebo run-in period might be useful in FSD clinical trials. That really has not been demonstrated, for example, in psychiatric clinical trials, if placebo responders are excluded and you only allow placebo non-responders to continue in the study. While this design is an option, a better design would be if a placebo run-in period establishes a new subject baseline while still meeting study entry criteria. There are also unsupported recommendations that the FDA has recommended as part of this draft guidance. Much of this appears to be related to their beliefs rather than data to support these recommendations. They have recommended subgroup analyses, that is, looking at, for example, women who have natural versus surgical menopause, women who are on hormonal contraceptives versus those who are not, evaluating women based on racial or ethnic groups. In the studies thus far, looking at HSDD and FSAD, there does not appear to be any reason to use these as a criteria for determining the success of a trial. Analyzing those subgroups may be valuable for some women, but it should not be a recommendation or a requirement as part of a study looking at a treatment for FSD. The FDA also recommended that available patient-reported outcome measures be modified and used in these trials. This is completely contrary to standard accepted practice in instrument development and validation. The FDA also encouraged the development of publicly available fit-for-purpose PRO instruments, but the FDA has actually rejected such a tool that was developed a number of years ago, the Sexual Interest and Desire Inventory, or the CIDI for females, which is well validated and has established cutoff scores. They also have rejected use of the total scores on the Female Sexual Function Index, or FSFI, and on the Female Sexual Distress Scale, or FSDS, desire, arousal, orgasm questions, as secondary endpoints. So these recommendations appear to be not only unsupported but confusing given the past FDA requirements. Now, I just have to say the FDA is flat out wrong on a few points. They have recommended a daily recall. They have consistently wanted daily recall because they seem to believe that women cannot remember past what's happened in the previous 24 hours, even though this has been allowed for studies involving male sexual dysfunction. However, there are real problems with a daily recall. We know that a daily measure of desire is not appropriate for women with HSDD. This has been studied in women, and they report that it does not capture their experience. In addition, it's highly reactive to situational effects. So, for example, if you got angry with your partner that day, then you may very well say, that day I had no desire, when in fact your overall response for the previous week or month was a much increased level of desire. So daily recall is really subject to mood and situational factors that influence the perception involving a specific short time frame, like the previous 24 hours, and actually adds noise to the assessment. Longer recall periods provide a more accurate assessment of desire, which is best understood as a state, much like mood is a state versus affect, which is experienced at the moment. In CNS studies, mood is assessed since the last visit, which may be 7 days, 14 days, or 28 days prior. Another useful comparison is appetite, which also occurs over an extended period, versus hunger, which is what we feel in the moment. Women have reported that a 7-day recall is consistent with a 28-day recall in measures used in female sexual dysfunction. So the Female Sexual Function Index and the Female Sexual Distress Scale. So that it probably doesn't, so that a requirement of a 7-day recall, much less a daily recall, is really inconsistent with what women report about their experience of desire. In addition, the recall periods for patient-reported outcome instruments should be consistent not only with the condition of HSDD, but should also be related to the drug, whether it's daily dosing. Recall periods for patient-reported outcome instruments should be consistent for the condition of HSDD and should take into account drug dosing, whether it's daily versus as desired use. So for example, daily use certainly would recommend consistent reporting over time, so 7-day or 28-day recall. Desired use would also be useful over that time period, but might also utilize an event-related measure. For female sexual arousal disorder, which is event-related, evaluation post-sexual activity should be performed, whatever dosing regimen is used, at least 12 hours beyond drug effect duration or the T1/2 of the drug. And changes in patient global impression rating of severity was also recommended by the FDA, but in fact, it should be the patient global impression of improvement that is used to determine clinically meaningful or important effects. That the uses of the PGI-S for severity is recommended as an endpoint by this division, as they seem to believe that women cannot determine their level of improvement from their state at baseline entry into the study, which should be determined by PGI-I or improvement. Again, this seems to be an FDA concern about recall, believing women can only accurately report how they feel right now. Both the CGI-I and the PGI-I are accepted endpoint measures in CNS clinical trials. Oh, sorry. Let me go back to before that last sentence. There is also a clinician global impression of severity and improvement, and both the CGI-I and the PGI-I are accepted endpoint measures in CNS treatment trials. Comparing PGI-S severity scores across time is not an accepted methodology in CNS trials. Usually, PGI severity scores are measured only at baseline. So the appropriate measure really should be the PGI-I Some still unaddressed issues. The FDA has been requiring an excessive alcohol study, and if that's going to be required, the FDA should provide a recommendation for tracking alcohol use during Phase 3 clinical trials, where it can be viewed in the naturalistic setting and across time, and where alcohol use is considered by the patients to be infrequent or moderate. The FDA should provide a recommendation for tracking alcohol use during Phase 3 clinical trials, where we get long-term data. Women are reporting on their level of alcohol use, and that can be related to potential alcohol use events. Also, a clear description of measures of behavioral change with an improvement in desire should be included. That would be things like initiation of sexual activity, increased levels of receptivity, change in avoidance behaviors so that your partner doesn't think that the woman is a clear description of measures of behavioral change with improvement in desire should be recommended by the FDA. This would include things like change in how frequently a woman initiates sexual activity, increase in her receptivity to partner approach, and decrease in avoidance behaviors in order to not have her partner anticipate that she would want to participate in sexual activity. So in conclusion, there is some improvement in the draft guidance with the removal of the requirement for satisfying sexual events as a primary endpoint. There are, however, continued unsupported requirements, such as daily recall of desire, an excessive 24-week duration of registration trials, and a separate analysis of pre- and postmenopausal women. There's still persistent discomfort in this FDA division with patient-reported outcome measures, and they fail to provide specifics on measures of behavioral changes with increased desire as secondary endpoints. Overall, I would say this draft guidance is a small step forward. Thank you.
Thank you, Dr. Clayton.
Hello.
I'm sorry, I really stumbled there. I guess I'm tired today.
It's early in the morning.
Yeah, well, that may be part of it too.
Yeah.
But I think you can figure out what I don't want to say and what I do want to say.
Well, we will edit this recording, Dr. Clayton, and then we will provide it to you. So if there is anything that you do not agree with, you will let us know and we will fix it.
Okay.
Okay?
That sounds great.
Okay. So we are done here. We don't have anything to add. Jeffrey,
Nope.
do we have anything to add? Okay. So thank you. We thank you again, Dr. Clayton and Krista. Krista, right?
Yes.
Thank you. Thank you both.
Dr.
Thank
Clayton,
you.
do you have anything to add?
No, thank you
No.
all for your support in all of this. And I look forward to hearing the recording and relating it to the slides.
Thank you very much.
Great.
And thank you for your support, Dr. Clayton.
Okay.
We
Have a great
Great.
day
Thank you. You
You
too.
too.
Bye-bye.
and a wonderful holiday.
You too.
Thank you. You too.
Thanks.
Yes. Thanks.
Bye-bye.
Bye-bye.
Bye.